Transcatheter edge-to-edge repair of the mitral valve is done for treatment of mitral regurgitation. Anterior and posterior leaflets of mitral valve are approximated using a clipping device and is similar to the corresponding surgical procedure known as Alfieri stitch. Earlier porcine study had used left thoracotomy for placing the flexible delivery catheter with a clip in the left atrium. The clip grasped and approximated the mid portion of the anterior and posterior mitral leaflets with echocardiographic and fluoroscopic guidance. Clip was detached from the system and the catheter withdrawn after confirmation of creation of double orifice. Everest cohort was a prospective multi-center single-arm study to evaluate the feasibility, safety and efficacy of the Mitral clip system. Among the 107 patients treated, 10 had a major adverse event, including one non-procedural death. There were no embolization of the clip in the study. Partial clip detachment occurred in 10 patients. Acute procedural success was achieved in 74%, and 64% were discharged with 1+ or lesser mitral regurgitation. 30% had mitral valve surgery 3.2 years after the clip procedures. Surgical repair was successful in 21 of the 25 cases planned. 2/3 of the successfully treated patients were free from death, mitral valve surgery, or mitral regurgitation more than 2+ at 12 months. There were 23 patients with functional mitral regurgitation who had similar acute results and durability. The Mitral clip device is delivered to the mitral valve through a percutaneous femoral venous transeptal access. The clip is aligned above the mitral valve and advanced across the mitral orifice before grasping and co-opting the leaflets. Everest 2 study was a randomized trial which compared Mitral clip versus conventional surgery for degenerative mitral regurgitation. 1-year result of Everest 2 showed that mitral valve edge-to-edge repair was less effective than surgery for reducing mitral regurgitation, but had superior safety and similar improvements in clinical outcome. Major adverse events in percutaneous repair group was 15%, while it was 48% in the surgical group at 30 days. Death rate was 6% in both groups. 5-year results of Everest 2 showed that even though surgery for residual mitral regurgitation was more often in percutaneous repair at 1 year, the need for surgery between 1 to 5 years was comparable in the two groups. The Mitral clip grasps the mitral leaflet edges and reduces the regurgitation volume and the preload of the left ventricle. In the long run, it reverses adverse left ventricular remodeling and improves clinical outcome. But the results may be poor in those who have long-standing left ventricular volume overload due to severe mitral regurgitation. These persons may have irreversible left ventricular dysfunction and poor prognosis. Mid-term outcomes from the Cutting Edge International Registry were reported in 2021. 332 patients across 34 centers underwent mitral valve surgery after TEER from 2009 to 2020. Median follow-up was 9 months after mitral valve surgery. Follow-up was 96.1% complete at 30 days and 81.8% complete at 1 year. The median interval from TEER to surgery was 3.5 months, with overall median Society of Thoracic Surgeons risk of 4.8% for mitral valve replacement. Mitral valve replacement and concomitant tricuspid valve surgery were performed in 92.5% and 42.2% of patients respectively. 30-day and 1-year mortality rates were 16.6% and 31.3% respectively. Authors mentioned that at the time of their report, over 100,000 mitral TEER procedures have been performed worldwide. They also added that the mortality and morbidity risks of mitral valve surgery after TEER are not negligible, and only less than 10% of patients underwent mitral valve repair. First set of journal references. Second set of references. Third set of references. Thank you for watching this video. Please subscribe, like, share and post your valuable comment below this video. Kindly press the bell icon after that for getting all updates.